All right, so the way this is going to work is I know there's questions out there, so don't be shy. If you have a burning question, just raise your hand, and Kyra or I will come to you and bring the mic to you. So while you're thinking, we'll go ahead and get started. Earlier today, there was a conversation, and I think this is actually for Dr. Pritchard. She's not in here, but I think maybe you guys could. Oh yeah, I didn't recognize you without your mask. So you mentioned palliative care in your presentation, and I think that might be a new term for some people in our community, and I was wondering if you could explain a little bit more about palliative care and perhaps how our community could use that, because I do think, you mentioned in your presentation that sometimes people think palliative care and they think hospice, but it's so much more than that. And there's also different state regulations of how you can access that. So I'm wondering if you could dive into that a little bit.
Yeah, and my voice is like on its last legs, so bear with me. But yeah, so palliative care, at least at many pediatric academic institutions, is a whole team of people that can include MDs that have actually done specialized training in palliative care, as well as social workers, nurses, nurse practitioners. So it's often a big multidisciplinary group. And at most places where I've worked or trained, it is not just focused on people at end-of-life care, but it can be focused on any patient that has a chronic illness that's impacting their life, especially if you're at a point where you need to make big decisions. So for example, if, unfortunately your child had been in the ICU for a while and you had to decide, do we need to get a G-tube, or, do we need to think about any big surgery? Is this a good idea? Yes, no. Or if somebody's experiencing a decompensation where their heart's involved, like thinking about ECMO, or situations that I hope none of you are ever in for yourselves or for your children. But suffice it to say that if you've got a chronic disease, you've got some big things to think about, and or you have chronic disease impacting day-to-day life, they can also be a team to help you navigate the specialists you're seeing and the decisions that you're making. I would say I've sent, a variety of patients to our palliative care team over the years with different diagnoses, and everyone gets something different out of it. Everyone, every family needs different things, but nobody has come back and said, oh, that wasn't useful. So it's just something, if that's of interest to you, ask your local team what resources you might have.
Just a quick follow-up. Sometimes, depending on your institution, the palliative care team also does the chronic pain management. And so if you're having issues with chronic pain, sometimes this is probably, we see this more frequently in the folks who are having problems, LCHAD and TFP patients who are having problems with their neuropathy. But sometimes there's these folks have institutions have a dedicated pain team. Sometimes it's in palliative care.
Are there any more questions? Yeah.
You guys are probably going to say you don't know, but I do have chocolate if anybody does want to try to answer it. Are there markers that you guys use to indicate how different or similar siblings might be? People, like, they're all different, right? Kanan's his own person, more on the severe side. Caleb has now come along, has VLCAT as well. His initial markers were a lot better. I mean, his CK at birth was 700, Kanan's was 5,000. He hasn't had any issues yet. He's 7 months. Kanan had lots of issues by now. Are we in the clear? Like, should we expect that this might be an easier go? I have chocolate, really good chocolate, if anybody wants to take a stab.
Dr. Vockley wants chocolate.
I'm not going to say I don't know, but you're going to understand that that's the answer anyway. When we look at severity of disease, there is usually a correlation within a family, because two SIBs in the same family with the same disease have the same mutations. And if you look at the expression of genetic disease, the variants that you have are always the prime driver of your clinical symptoms, your phenotype. But when we say we know what your VLCAD mutations are, you have, depending on how many genes you want to say, but if we say there's 25,000 genes that play into making your body you, we now know one of those genes and how it affects you, but there are still 24,999 that we haven't tested. I actually put in a grant a whole bunch of years ago asking just this question, and the NIH in its wisdom said, no, we're not going to publish that, or we're not going to fund that. So we don't know the answer for any disease, let alone VLCAD. Your experience with your two disparate children thus far represents a snapshot in time, and we certainly hope that continues to be the case, that your newbie will continue to be very mild. But frankly, I wouldn't bet on it. I mean, I think you still have to have a very, very high level of suspicion and caution that the risk factors are all still there. And so under the right circumstances, which perhaps Keenan had and haven't presented themselves yet, will ultimately manifest. The other thing to keep in mind is this is almost a self-fulfilling prophecy. If you've had an episode of rhabdo, then you're more likely to have another episode of rhabdo in relatively short order. So this kind of you got it a bad stretch is real. And we're looking into that in a variety of different ways now. One of the things that I think is playing into that is this inflammation stuff that I talked about a little bit earlier. That's a really long-winded way of saying we don't know, and I guess you get to keep your chocolate. There's plenty of food out there, by the way.
Are there other questions?
Hi, everyone. I also think you guys are going to say you don't know, but I'm going to ask anyway. I don't have any chocolate,
Ask us something we know. Come on.
Have there been any studies on lifespan and health over time in people with VLCAD or other LC-FAODs? I mean, maybe in mice, and I don't know if that'll translate to humans, but is there any information on that at all? Like, when I'm 70 years old, am I going to be significantly worse, or will I live to 100, or am I going to live to 150? You know, is there any information on that at all? I know it's kind of a morbid topic, but I'm just curious.
No, I mean, this is one of my favorite topics too, because I think a big part of telling any family, like with a newborn child, like prognosis, is saying, is this life limiting or not? And the answer is, I wish we knew. I think I went to another family support group meeting recently where all the clinicians went around and said how old the oldest patient they took care of was, and that was like the best data that I've seen for that group. I think for VLCAD, I think we were talking about this earlier in the clinician roundtable, and I think we came up with, Chad is here, and he's one of the oldest people we know. I think I know someone in his 70s with CPT2, and I know someone in his 60s with TFP who was diagnosed late in life, and that, so much of what we're doing right now, especially on the, in terms of what's going on with adults, is anecdotal, and we're still trying to find the best way to kind of get all this institutional knowledge to the broader world.
Can I say something to that? I can't speak to the science of it, but one thing I want to say, and I'm going to put a couple of you on the spot. It's so exciting for us at Mito Action, right? You talk about life limiting, and we have 3 people in this room who are defying the limits of what this disease can provide. And so Ali, Addie and Alex. They're all recipients of the Mito Action Matthew Hardy Camper Scholarship Fund, which provides scholarship funding and support for our Mito families, our Mito kids that want to go to college and to defy the odds. And so let's just kind of celebrate them all because they're defying the odds. And I hope you guys all look to them for inspiration to know what's possible.
Yeah. Let me just summarize one of the other comments that I think was Dr. Gillingham brought up at the round table that Dr. Gold was referring to, and that is, you know, first of all, remember most of these disorders are only about 30 or 35 years old. So the reason we can't give you that information is that before we knew what they were, people were dying from them. And they died of things we didn't know. You know, they died of sudden death, or they died of otherwise unknown heart failure, unknown heart failure. And that didn't respond to any normal treatment. Well, that's because it wasn't usual heart failure. Newborn screening has changed all of that. And what we used to call the natural history of the disease is changed by the fact that we now identify it before you get sick rather than after. And so we all have our personal oldest patient. None of that makes any difference to you because all of those personal oldest patients were born after newborn screening. Newborn screening in most states is no more than 15 or 20 years old. So those of you who are older than that were identified because you got sick. And you got sick in the time frame between when they were defined and we started doing newborn screening. So when I look at the strides that we've made since we first identified the diseases, started figuring out what was wrong in those diseases, and started trying to come up with therapies, we're at an inflection point. Thank goodness we have Dojolvi, but we need more. We'll have more, and I keep saying my crystal ball runs out at 5 years. But somewhere in the next, I'll go on a limb and say it's 10 years. We're going to have more treatments available, and the question is not going to be how long will I survive, but what will give me my best lifestyle. And so I understand you all worry about getting sick suddenly and having catastrophic outcomes, but you know what you have, your family knows what you have, and we know what you have, and all of our goal is to keep that from happening. And you know, never say never or always, but we're pretty sure that the reason we don't know what your life expectancy is because we have just pushed it out by a lot, and we're still pushing. And exercise, be healthy.
That's right. So maybe a little bit on that same topic. So more patients being identified through screening, more patients living longer. From what I understand, a very limited number of you all. So how can we as families be helping to fill the pipeline of people in your profession? Like, is this just we need to write more and bigger checks to our children's hospitals if we have the means? Do we need to be like brown bag lunching with biochemistry students in college? Like, what is the realm of things that families can do to help make sure that people know that this is a profession and it's growing and we need them?
I'll take a first stab at it and say thank you very much for allowing me to host 5 PT students from the local school here, because it gave them new exposure to conditions that they haven't gotten to learn about yet. And they're, in turn, being asked by their school to present on what they've learned from this conference. So my hope is that with more outreach, we can reach more medical professionals and encourage them to learn about what's going on and all the knowledge that we currently lack. Because there's a bunch of brilliant minds out there. If we can get them all to put their thoughts together, we can make big strides moving forward.
And I would just say that we discussed that exact thing in the clinical rounds earlier, and I'll just try to summarize. Our thoughts were to get medical students early, teach biochemistry differently, try to work on lowering student debt for docs who want to go into genetics, and potentially try to increase compensation for the field. Did I hit? Yeah.
I'll also add that as patients and families, you play a really critical role in training the next generation of biochemical geneticists. And that doesn't mean that it's your job to act as, you know, a guinea pig for a medical student or a resident. It just means that those people are going to be involved in your care. And so I think being cognizant of that and providing thoughtful feedback when it's warranted, both to a trainee or to their supervising physician, but then also sharing your story, because I think when we as human beings relate to one another, we become interested in things that we didn't know existed. And I don't know anyone up here who didn't have kind of a transformational experience with a patient that helped drive their interest in the field.
You said what I was going to say, probably more eloquently than I was going to say it. Yeah, I mean, I was going to say something along the same lines of just being welcoming of trainees that you encounter along the way, whether they're physician trainees, nursing trainees, because everyone just wants to help. And when they learn about these disorders from you all, it just leaves a lasting impact and motivates them to want to do this really exciting job of trying to help care for metabolic disease. And I've honestly never had a family ask that question, and it just warms my heart so much. So thank you for asking that.
You might have noticed by now, but I'm a guy that's you know, a glass 1/10 full kind of person. I'm very optimistic, and the one thing we have going for us in this profession is that if you ask anybody who goes into medical school why they're going to medical school, right? What do you think the answer is? Well, they want to treat patients. They want to help. They don't want to diagnose complex disease and say, bye, sorry, I can't do anything to help you. So as we get more and more therapies here, and this is across the spectrum in metabolic disease, as we move from being physicians who diagnose and dump, sorry for the language there, but that's what we used to. We never really did that, but we would say, okay, here's what you got. We know what it is. Have a good life for as long as it lasts. And now we're becoming more and more therapeutic oriented, and that's going to make a huge difference. We still have to break that barrier that everybody else has been talking about. How do we get students to know this? How do they get to recognize it? One of the things that I do with my medical school teaching opportunities is I bring patients in and I put them in front of students, and they tell their stories. So if any of your docs ask you to do that, yeah, please say yes. It's a great experience. A medical student will forget what a fatty acid oxidation disorder is as fast as they walk out of the room from the lecture. But if they see one of you there and you talk to them about your journey, it will be indelibly emblazoned in their minds, and they'll forget everything else they learned from that lecture, but they'll remember that patient. So you're very important in this.
Before we move on to the next question, I just want to add to that. I had a geneticist tell me that she got interested in genetics in middle school. So that was to me fascinating, because as parents, right, we have some teachers in the audience. So getting your kids excited about the mitochondria super young and in the classroom, right? There's an in there. And then in 7th grade, they study the mitochondria. Unfortunately, you know, some science teachers are more exciting than others, but know that that's like a standard these days. And so like having scientists come into the classroom or going in yourself and like talking to that age group, maybe once your child is not in that grade, or maybe if they're, you know, but it's something to think about as parents. That's a way that we can get involved to encourage people that like this can be impactful and make a difference as well.
And that is actually what I was going to talk about, is that I'm a genetic counselor. I didn't know what genetic counseling was until my 2nd semester sophomore year. And so I had to scramble a little bit to get what I needed. So I actually haven't been invited to speak at a high school in quite a while, but when I was on a regular basis asked to go, I loved it. Because it gets the word out about the field in high school, not waiting until 2nd semester sophomore year. So I did it from a different perspective. I was trying to recruit genetic counselors, right? But I also went through, you can combine your interest in the law and genetics and all the, I don't know if it was probably ASHG, had a diagram that I would use. I would also get them to draw their own family histories, and sometimes it was extra credit. But that was a really rowdy time, but it got them doing something and understanding what we do. And then we'd get into some ethical questions. And I'd walk it up harder and harder in the decision tree. But I would challenge us as clinicians to perhaps seek out those high school biology teachers and go. If I went for the day. I said, okay, you might be teaching genetics, but what about all the other science teachers? Can I just, because you're not doing it 6 hours a day, where else can I go and speak to make it helpful for the students to get the word out? So maybe that's something that the geneticists, and specifically biochemical geneticists, should think about.
I have to tell you, I taught 1st and 2nd grade science. I went to my kids' classes and brought experiments. I was Bill Nye the Science Guy, because I looked at their curriculum and I thought, holy crap, this is boring. And I went to the teachers and I said, you know, do you mind if I help you spice this up a little bit? And they were delighted to have me. It was great fun. The kids responded amazingly to it, and so you know you can provide that kind of input, and you don't have to go and bring experiments. I'm a scientist. I had all kinds of reagents in the lab. I could just pull them together and walk across the street where the kids' school was and do it. But you can be that spark that they're not even going to remember it when they're in high school. But you might have sparked an interest that would never have otherwise have been there. So that it's never too young to talk about science, with your kids, with your kids' friends, with whatever venue you can get.
I was just going to comment on that, your comment earlier about how they were impacted by your story. I don't know how this guy got my name, but a professor at UGA in Georgia has asked me to come for the last maybe 4 or 5 years and talk to their genetics students. And, you know, I'm not an expert, right? But when I tell you these kids, when they're kids to me, for 2 hours, they had like question after question after question. They are like glued in, and tons of questions in the chat. I mean, they are so, you can tell they're impacted, they're engaged by it. So I think that is such a meaningful way, it's something that we can do, right? Like we maybe don't have $20 million, or I think we're up to 80 million at this point. And we don't have that, right? But we can go to a class and share 2 hours on a Zoom twice a year, once a semester. And it really seems to be impactful. I mean, they are like really, and I'm okay, I'm not like super engaging, right? But they are like glued in, so I think that's something we all could do.
Yeah, and so it's Dr. Corson has a registry.
Oh, yeah, Dr.
And he partners parents with clinicians who are interested in either having them do rounds or science teachers who are interested in having them come in and talk. So there is like a registry that you can sign up for that, but also if, you know, you can ask your clinician. Like I like to bug my clinicians, if you ever need anybody, you know, to come in and talk. I think that's a way that parents can get involved too. Is there any other questions?
If you have a physical therapy school near you, they should offer clinical experiences where patients can volunteer to go in and spend some time teaching the students about different things. When I was a student, we had that with patients with spinal cord injuries. We had different days with pediatric patients. We had people come in who had amputations to teach us about the different prostheses that they use. So if you reach out to them, usually it's the educational coordinator or the clinical coordinator who sets that up. You just Google the therapy school near you and send them an email, say, hey, if you're ever having a day, I'd be interested in volunteering. It's usually great fun. They offer you food and you can teach a whole bunch of students.
I have a question. My dietitian will supplement for deficiencies and different things, and at the time it makes sense why we're doing it. But I heard Dr. Gillingham's caution, because now I'm look back and I'm on a hodgepodge of supplements like fish oil and DHA and CoQ10 and several things. Should I go back and challenge my metabolic team to maybe do a little research just to make sure what we're doing follows with data, or is kind of what we established okay, because that's why they supplemented?
That's a great question, Alex. I think it's always good to just revisit it and say, is this still a supplement I need to take? But I bet you there's a reason they started those supplements. I don't know your exact story or why they tried, say, DHA. Your plasma DHA was low, and so they added it. But yeah, I think it's always a good idea to go back and just ask them, is this still something that I need to take? So.
You in your presentation today, Dr. Gillingham, you had several different supplements on there, and I'm curious, like taurine, and are all of those, I know you can test CoQ10 levels in the blood, are the other ones something that you can test, or how hard or easy it is to test for certain kind of values?
Those are hard. So taurine is not a standard amino acid that, at least I don't believe it's a standard amino acid that comes out on any amino acid panel. You can ask them for it, but I don't think it's a standard one. It comes off on my metabolomics panels. Glutamine's there, so I don't think that one's hard to do. DHA is a fatty acid panel. CoQ10's hard to measure, I think, so I don't know that that's a routine blood marker that we measure. Did that cover the ones?
Are there vitamins and stuff, like the vitamin E and D, or these?
So fat-soluble vitamins are near impossible to measure. There's only a handful of labs in the country that do it very well, and almost nobody measures vitamin K. So fat-soluble vitamin D is easy. Vitamin A and E, very, very difficult. Vitamin K, almost impossible. So vitamin D, every hospital does all the time. So that one's easy. And the water-soluble vitamins, there are labs that do them, but it's not a routine lab that's going to do niacin, riboflavin, paroxetine.
And if I can make a little bit of a commercial here, and that is to say, that everybody's everybody wants to do what's best for you, right? Everybody, you want to do what's best for yourself. And so you'll have lots of people throwing things at you saying, well, why don't you try this? You know, it worked really great for me for, I don't know, I had a swollen big toe for a week, and I started this stuff and it went down. Well, it was going to go down anyway, but so there's all of that kind of stuff. There was a question at one of the earlier talks about you know, well, if it's just one anecdote, that may be just one anecdote, but what about two anecdotes? Well, that's just two anecdotes. You know, this is not a situation where 1 + 1 = 2. 1 + 1 = 1 + 1, and you would do well to look at your lifestyle, and I'm going to pass this to my left in a second, and your diet and your nutrition, and say what am I doing holistically to take care of myself, and you're going to get a lot more mileage out of that than trying to pick one thing out of the thousands of chemicals that we can measure in your body, that might be up or down the day we measure it, and the next day go right back to normal when we measure it again. I think this idea that we heard about this morning about what you can make, what you can cook for yourself, what you can eat, starts with what anybody else can do, and you can be very holistic about that, and then there's this little piece of what good nutrition is that you have to modify for your disease. And we were having a great conversation about this earlier. Love the way you
yeah, sure. Just to add into that, the base, building that base, that foundation, we look at larger sets, metadata sets from places like the blue zones, the longest lived people in the world. What do they all do? And there's large population studies over years. That's good stuff that we can use. Does it fix everything? No. Does it fit in with your medical care? Yes. It's a great foundation to build on. We touch on so many things. It leads into conversations like epigenetics and your expression of your genes. Your genes aren't a permanent code. In some cases, they dictate what you have and what you don't have, but you can turn or nuance levers of that. You can advocate for yourself through your diet, through your lifestyle, through nutrition, and that's what anybody can do. And a lot of the work I've done previously, people don't get to that point in their lives until they've had a transformative moment. So it's someone leading up to heart disease or heading into a quadruple bypass or type 2 diabetes for 17 years. And it hits them. And they have to make a change. So they adapt their lifestyle and they make a change. And we see great results from that. That is also true of many of the people in this room. You've already had your transformative moment. You've had your diagnosis, or your family has. And to do the best we can with it starts with what we can do when we can do it. And nutrition and holistic living and lifestyle, it's really becoming a burgeoning topic. Lifestyle medicine, functional medicine, and how that fits in holistically along with your medical care is super important. And I'm a big advocate of it, and I'd love to talk to anybody else about it. I can share more. I have data and studies and books, and there's a whole plethora of things that I can add to that. So thank you.
So I was going to ask, so when I was diagnosed with CPT2 10 years ago, and you'd search it on Google, you'd find, you know, a Wikipedia page, right? Some guy's blog on the internet from 2006, and that was about it. Now it seems like there's all this information out there, right? But we all kind of live in this, you know, LCFAOD echo chamber. So I wanted to ask you guys, do you notice in the medical field, is there a lot more interest in people joining the field and studying it? And, you know, are these conferences getting bigger and bigger?
Oh, I mean, I'll edit that a little bit, Dr. Vockley, and say, you know, when we think about the ACMG, so the American College of Medical Genetics, right, like my first meeting over 10 years ago was so much smaller than it is now. So while the number of biochemical geneticists has not increased, exponentially as we might like, I do think overall our field is definitely growing, and there's more interest. And like we said earlier, it's patients like you meeting our trainees, meeting people that helps grow that. So it's not all doom and gloom. It's getting better, but it's a slow process.
You all are doing better than we are. The fact that this many people are here, whereas 20 years ago, you'd have a hard time finding two families sitting together in the same room at the same time. So this is really important, and even the different disciplines on this stage are a testament to how much more broad, interest is maybe the wrong word, but availability of expertise. And I come to one of these meetings and I never fail to have my eyes opened. I just, it was this I now have a completely different way of thinking about how we should feed ourselves, and how we should feed our patients. I used to think in terms of dietary restrictions, and I hate to say it, but I'm old, and it's hard for me to learn new tricks. And in a very short period of time, this revelation of where we're not restricting you. We really actually want you to eat well. But here's how you have to change it to do that. The idea that we don't want you to be sitting in a chair all day because you're worried about getting rhabdo. We want you to do exercise, and that I've advocated for years, but I've had really no way of quantitating that. And then suddenly there's Pam, and she's going to help us with that. And all of the students that she worked with today are now interested in this. It's this one step at a time, and I was just being a little facetious and maybe a little grumpy when I said nah. There have been great strides. The fact that we identify these disorders for newborns has just, I mean, it's identified, or it's brought you all to attention in a completely different way. And when I talk to parents of a newborn, what I say is our goal is to keep your child healthy as long as possible until we have all of the tools in place that we need to help them. To cure them. I mean, that's what gene therapy is, and ultimately that's what we want to do. But until then, we have all these other tools that we're going to have available to us that nobody ever dreamed about 20 years ago, which is great.
The other thing I'll add is that it's not just us. In order to come and see a biochemical geneticist, right, somebody has to think, could this be a biochemical disease, right? And I think that messaging, at least in centers with genetics teams, has gotten better, because I'm getting referrals for folks who've had rhabdomyolysis, and I know that the majority of those folks are not going to have fatty acid oxidation disorders, but I appreciate that someone sent them to me to rule it out. Right? So I think certainly with the explosion of genetic testing, there is better recognition that these conditions, probably aren't quite as rare as we once thought, and better exposure for clinicians in other subspecialties to start thinking about them. And we hope that they think about them sooner. I don't know that that's true, though.
Are there other questions?
Hi. I was just going to ask if you guys have noticed whether or not, like, if he has muscle weakness, I think a decent amount. Will that just continue to get worse, or with the proper diet and care, could it potentially get better? Do you have enough studies to give me an answer to that?
In general, other than LCHAD TFP, we don't view these disorders as being degenerative. Even with LCHAD TFP, there is a tremendous amount of value to be had by early diagnosis, early intervention, and a strong physical activity regimen that will bring you back or keep you from deteriorating. He said there are always eye-opening moments in this business, and one of the eye-opening moments that I had was when I heard from Alex about this physical therapist named Pam, who was working with her and had put her through a year-long course of physical rehabilitation, and with remarkable outcome. And my response to that was, that's great, but you just told me that means there's two of us who know. We got to get this story out, and fortunately, and Alex introduced me to Pam, and I'm pretty persuasive. I was able to convince her to write this up and put it out in the literature. And now, whenever a physical therapist says, "What should I do?" I send them Pam's paper. And I say, "Now you don't have to do all of this. You know, this was an extreme case, but you can learn from this, and these are the kinds of things that can happen." So good physical therapy, good nutrition, and hopefully we continue to come up with drugs that will help, and you know, the future is for someone as young as your little one is still it's not written yet. So be hopeful, but be proactive to make to turn that hope into reality. Keep working on it. This is not it's not written in stone.
So would you recommend like PT consistently, even when he's doing good, just to keep him strong?
So I would highly recommend tune-ups. And by that I mean ask any doctor that you see for a script for physical therapy, and honestly request them to make it as general as possible, of just like muscle weakness. The more general they keep it, the more I can do. When they make it really specific is when I'm really restricted, and that comes down to insurance. But if you take that script to a therapist and you have certain goals, like you say, well, it doesn't seem like he can keep up with his peers when he's walking on the playground, or he has trouble, he fatigues when he goes up and down stairs. That's something really specific that they can work on, and it wouldn't be forever. It would be, okay, let's take an 8, 10, whatever week period, go over some different exercises, and then let you go out and practice them in the real world. And then maybe a year later, he grows, goals change, come on back. Okay. Going back to what was said earlier, the weakness that you're seeing is definitely present. I think that's one thing that really struck me from that research in the lab in Eastern Carolina, that they were looking at these muscles in the mice, and the alignment of those sarcomeres was that kind of funky zigzag, when in the controls, it's like these nice orderly bands. So what that results in is that inefficient contraction of the muscle. So they're producing less force and less power, which leads us to, okay, well, how do we have to train this muscle to get more power? So that's something that I'm really interested in looking forward of, okay, maybe we need to do some combination of eccentric exercises with different exercises. Maybe we need to try that in a pool. I'm not sure exactly what that answer is yet, but I will say I haven't found anything either in my clinical practice or in the literature that says you guys can't get stronger, you can't gain muscle strength. There are patients with conditions that is the case. I see patients with things like ALS or MS where it's more progressive and degenerative, like Dr. Vockley mentioned. And with those patients, I really feel fortunate if I've maintained where they are. That is progress, as opposed to, okay, we started at week 0, now it's week 6, and you got weaker. So they're just different goals. If I was seeing any of you guys, I would write goals of, okay, you'd improve a muscle grade of strength, or like just different. I haven't found anything, and you can correct me if I'm wrong, that says you cannot gain strength.
Thank you.
Yeah, you absolutely can. And just one final comment is when you go for any sort of therapy, you know, if you're in early intervention or occupational therapy or speech therapy, much of the therapist's job is to teach you as a parent to treat your child, because that therapist is with you an hour a week for maybe a few weeks, and then you implement that for forever. And this is one of the hard things about having a condition like this is you really never can just say I'm gonna stop. I'm better. I'm not gonna get any worse. I'm not gonna get any better. You always can get better, and that's going to be you're going to be your child's best teacher, your child's best advocate, your child's best therapist, and everybody else is there to help you help them.
Before I ask my question, I do want to kind of respond to you a little bit and say, never get complacent with your child just being okay. So like if they're feeling healthy, try and push them to be a little more active. Obviously, I'm not a doctor, so don't just do what I'm telling you, but like if I'm feeling well one day, I try and exercise, even if it's aerobic light exercise, walking, stretching, even if it's a little bit of anaerobic exercise, I try and push my body. So when I'm sick, I rest, but when I'm good, I can know that I will be better. And I've heard from a lot of people here and from doctors that when you do exercise, when you're healthy, it does make you feel better later on. Your body is stronger and can handle the sickness better. So I would say always keep trying. Don't just think, okay, they're healthy, I don't want them to do anything. Yeah, but I'm not a parent, so that's just my advice from my personal experience as a patient. Yeah.
And that ties into something I tell my patients all the time, that life is never easy. Life is really hard, but we can overcome some of the obstacles life gives us by being stronger. Who knows what we all face at different days. We may end up in a car accident and have maybe a concussion. We may sprain our ankle. We may get COVID. Who knows? The stronger you are before something like that happens, the better you are on the other side. I see that a lot with, right now at UPMC, I'll help them out on the weekends, like in the neuro ICU and on the ortho floors and things like that. And it's prehab before like elective surgeries is a growing thing, and I'm so grateful that we're supporting that much more, because we're seeing better outcomes before people have joint replacements, back surgeries, things like that, of training certain muscles to give you more stability before having something invasive happen to you that weakens you.
I also had a question now about, do you guys know about anything going on internationally? Like we're all here from different states, but I'm wondering what's going on in Germany, in Japan, in Italy. And is there anything interesting we should know about, new updates, new research?
So the I in Inform is international.
Perfect.
And yes, we meet once a year. We're meeting in just a few weeks in Portugal, and that will be an international meeting where we all exchange ideas, research, and best practice. There's no such thing as localized research anymore. The internet makes everything available to everybody. We're all in this together, I think, is the banal way of saying that.
Is there anything cool going on right now? That was there too?
Talk to me afterwards. I still think we're the epicenter in the States. Europe is a little draggy in terms of fatty acid oxidation disorders. They can't even decide if triheptanone works or not.
Well, let's give our experts a round of applause. We really appreciate all the questions that you guys had. We'll have another expert panel tomorrow. So if there's more questions out there, write them down, bring them back tomorrow. We're gonna take a quick 5-minute break and make sure you get your t-shirts on, and we're gonna meet back on the stage for a picture. And then the way it's gonna work later tonight is meet up with another family and grab dinner. There's a list of different menus that we had posted on the website for ideas if you're looking for a local place. And what was the other question? Oh, tomorrow morning we'll have continental breakfast here again at 8 o'clock. So if you want to reconnect with people, we'll be here at 8. And then at 9:15, 9:30, we're going to have our story moments. So Ali shared a little bit about his personal experience. Those story moments, that's what it's about, us learning from each other. And so I hope everybody will be back here early tomorrow, including the clinicians, because it's a great way for you guys to hear from our families about their personal journeys and experiences. And thanks so much for everybody, and we'll see you in 5 minutes.